The methodology was using one-to-one structured interviews with GPs around Birmingham, serving BME communities. And it was quite hard to get hold of GPs, as you can imagine. And for some of them, it took like 3 or 4 months of them saying yes and forgetting and politely reminding them. But the persistence was rewarded because some of the most valuable interviews were coming from the busiest GPs. So as they say, if you want to get something done, ask a busy person. I also interviewed some staff from voluntary sector organisations who were delivering social welfare benefits and employment as they had started working with GP practices, just to see how that looked from their end of things. Going back to the GPs, so looking to see how well embedded the various health and well-being outcomes that their patients obviously would want, and they would want, how well embedded they were in the practice. So I was asking GPs how satisfied were they with the level of health and well-being support that they could provide. They were frustrated because of the working pressures that they were under, and generally they're not very well satisfied, but we'll come on to that. And then asking them how well embedded are the health and wellbeing services in the GP practices, because they were obviously aware of all the health issues, but there was quite a bit of difference between which services were not well embedded. And to ask them about how well they work with voluntary sector organisations. As you will see, there wasn't so much of a relationship. And what they thought about the possibility of having a trained health and wellbeing advisor within GP practices. And what they thought some of the main barriers to health and wellbeing affecting the communities that they served. And they came up with some quite different answers. And then to try to get some idea about what the key business drivers that are shaping the health and wellbeing services that actually exist. GPs generally dissatisfied with the level of health wellbeing support they can provide, whether it's social prescribing around exercise or diet. And they said such things that, well, we've only got a very little amount of time. Some were saying, well, we do our best, but most of the patients don't listen. I asked them about how well informed they were about health and wellbeing research and resources in the locality. And I was not really surprised that they weren't that well informed about those resources in the locality just because of the pressures they work under. But I was surprised that research, for example, around diet, that shows how changing the diet, for example, around more of a whole food, vegetarian-based diet, can have profound positive health outcomes. They weren't aware of that. And there wasn't, as some of them said, there wasn't a sort of health and well-being communication of any sort that came round to them. Some of them thought that there was a role for a trained health and wellbeing advisor to work within the practices. Some said that the staff that they've got already perform that function. And the communities that they serve differ, and the support needs also differed. Some areas you've got addiction is a problem, more of a problem. And others, it could be the diet or combination of such things. And for the health and wellbeing services to happen, they obviously need to be sustainable. There was one GP practice, that was very innovative and tried to get a number of initiatives going and set up like a voluntary sector sort of partner organisation to work with them, but they couldn't get sustainable funding. And for example, they wanted to set up a training kitchen because a lot of people they came that were affected by poor diet, didn't know how to cook, So, practical things like that, but they couldn't get the means to do it. And generally, just would say that there's quite a bit of scope for GP practices to work collaboratively between themselves and with other voluntary sector organisations to improve the impact of health and wellbeing services, because obviously those sort of things are sort of holistic and longer term. It seems to be that some of the larger practices are able to offer more service. When you've got just the small practices, it is a bit more challenging. So in terms of services that were well embedded, so advice and support around healthy eating, they said it was well embedded. I think from what I could glean from the interviews, from the point of view of giving advice and information and the consequences of doing the right thing and the wrong thing, that was clear. But there was the issue of giving ongoing support and sustainable support, and then that raised the issue of maintaining the motivation to change, which a number of GPs says was a real challenge. So in terms of mental health, that was, they said that was well embedded. Quite often through referral to specialist services, that's what they tended to say. But it's a little bit surprisingly, with the exception of one surgery, social prescribing was not well embedded. Some were quite keyed up, others, yes, they'd heard of it, they heard one of their GP practice somewhere else was trying it out, so that seems to be a new area. But advice on housing, welfare issues, supported employment were not well embedded. So you might think, well, that's not necessarily the primary job of a GP practice, which obviously isn't. But clearly, there are a lot of social issues facing people which impact on their health. So it's not really a joined up service as yet in many cases. Their committed relationship counselling was poorly embedded, but domestic violence support was well embedded. So I think in terms of, as you would expect, safeguarding measures and procedures, that was very good, and seemed to be strong almost every case. But not so much in relationship counselling, or they didn't even, those that said that wasn't poorly embedded didn't say, well, then we refer to so-and-so. It just seems to be a bit of a weaker area. And with one exception, support with addiction was well embedded, again linking into specialist services, and the GPs felt that was effective. Only one surgery had spiritual well-being that was well embedded. That was looking at sort of the holistic well-being of the patient, and that was the one, the practice that scored the best on the overall embedding of health and wellbeing services. One comment, which I think is something that's worthy of looking into further, from one GP, 1 in 5 of the patients that he works with have got unresolved childhood issues impacting on them addressing their health and wellbeing issues. So it might be like smoking, addiction, obesity, whatever, and that they want to obviously get better. They want to deal with it, but he finds it. He said he finds it quite difficult to actually make a difference because of these unresolved issues. And 1 in 5, when you look at a GP practice of like 3,000 or 4,000 patients, is a lot of people. As I said, yeah, some communities, alcohol, unemployment, isolation are major issues. And poverty wasn't always said to be the main issue in poor areas. One GP said, well, I get my patients being picked up in BMWs and Mercedes. but it's deprived area, lots of poor housing and genuine poverty. And he said that with his particular practice, there are fatalistic community attitudes. For example, my grandmother had diabetes, my mother had diabetes, and I'm going to get it. And there's not much that can be done about it. And he was getting really frustrated because he was advising them, and there was sort of, like he said, the patients are nodding their head, but they don't take his advice. And then they end up getting into worse health problems, ending up in hospital. I put to them, and I just asked, would in some cases, when you're working with poorer communities, the value of, if you offered incentives to encourage people to change their diet, lose weight, there was a difference of opinion. Some thought it wasn't ethical, it was patronising. Then another GP said, well, why wouldn't I? Of course it would be beneficial. So there were a few GP practices who are working with a voluntary sector organisation and that organisation goes into the practice and delivers welfare benefit advice. And that's working quite well. There are now 3 GP practices who are giving this organisation regular slots because it helps the practice manager is able to sort of work out who it is that maybe the issue is not necessarily medical, so it saves the GP's time for like wasted appointments, and so that's just been going for about 3 months, but it's looking encouraging. Just some broader issues. When looking at health and well-being, it's obviously looking at the level of a local population that's got to be sustainable and fundable. So maybe the GP practice role as a health and well-being champion, maybe that can be extended. If you've got effective health and well-being services being delivered, being planned, it's not something that can demonstrate its impact quickly. And when I asked one GP, he said, well, yes, you probably need 5 years to demonstrate the impact. So clearly, if that's going to happen, then there needs to be the clinical impact data, which I was talking about earlier. And that's one of the things that I'm just working on at the moment with a couple of voluntary organisations, is to encourage them to collect that data around the social welfare interventions that they are making. About targeting communities to be empowered to improve their own health and well-being, just picking up on what that GP was saying, that in some communities, it's not necessarily absolute poverty is the issue, it's more to do with lack of understanding, attitudes and that sort of thing. So he said, I challenge basically saying that the community has to take responsibility for its own health and well-being. Yes, I've got my job to do, and I do it to the best of my ability, but I can't fix this problem by myself. The communities, they need to play their part. And so one small thing, I'm just working with Nick Hamid on one community education initiative around diet, obesity and heart disease to try and respond to that challenge. And then a further challenge, commissioners need to invest in proven holistic health and wellbeing services. So getting the evidence, which is what the commissioners want, I think is a big challenge. And I think the GPs are a bit frustrated that they can do more, but the way that the system is set up, principally around a clinical model, and the way that sets the priorities, restricts what they can do, because they can't put too much time into developing health and wellbeing services, because that's not where the funding is. Yeah, just some other broader issues. As I said before, health and wellbeing initiatives that work do take some time to mature and to evidence. One of the things that one GP mentioned is, he said, and he's referring to mental health in particular, that if you have an effect, and he said that he gave an example of a homelessness project, if you have an effective way of dealing with the mental health issues and to promote health and well-being, what you're going to get, first of all, is an increase in costs, not a decrease. Because the issues that people got will come to the surface, and then you have to work through them. But over the long term, that's where you can get the payback. So if you've got commissioners who are looking for an immediate evidence base, then I think some more consideration needs to be given to, well, what sort of reasonable upfront investment is made to take account of that. And in terms of embedding health and wellbeing support staff, it could be around social prescribing, or it's managing, changing diet, managing weight, and such things. You've got to have the right people with the right skills, and they need to be trained, because you've got to have someone who understands the clinical side of things to some degree. They've got to understand what health and well-being resources there are out there in the community, what are reliable. They've got to understand in terms of like the costing, and most importantly, they've got to have the motivational skills in order to work with those from disadvantaged communities who may have a variety of barriers, which may be social, financial, emotional. So if you've got the right staff, it can really make a difference. But it's not necessarily a quick fix. And finally, the healthcare system that incentivizes patients to keep well, because what we have at the moment is GPs working very hard under difficult conditions to treat symptoms, but those symptoms, maybe 30–40% of the cases, they take time to develop, and as a result of lifestyle. So if the overall system is not incentivizing people to keep well, then they're going to get sicker earlier and cost more to the NHS as a whole. So that's why I was saying, in terms of like a social investment bond, the way that that's thought through, the scale that it operates at, what are the clinical metrics that might be used. That, there is a great opportunity there, and there is some appetite for it, and there are people within central government. I was informed by one civil servant who's looking at that right now. But finding a way for that to be put into some sort of practical framework in a city like Birmingham, I think is a challenge for everybody. And finally, so that was just a quick summary of the conversations I've had with GPs, and I'm just currently working with one voluntary sector organisation in Lozells, who have been delivering lottery-funded project to older residents in the area, providing them with various forms of advice and social support to see what impact that their work is having on reducing the demand on the NHS and GP services in particular, and that will involve USIC community researchers. And that's where we're up to at the moment. Thank you very much.